I'm Juliette Perzhinsky, and I'm an associate professor of medicine at Central Michigan University College of Medicine in Mount Pleasant in Saginaw, Michigan. We have two campuses, so I consider myself from both. By background, I'm an internal medicine physician with training in patient safety. And one thing that I do at my academic institution at CMU is I teach in a variety of settings in the clinical teaching environment, in the clinic. I teach residents, I do teaching of medical students, and just last year I had expanded with the interprofessional education curriculum to other health professional students, including PAs and NP students. And so more specifically, the expansion of the project to me is really hinged on a patient safety framework, of which we're trying to address the opioid crisis by instilling the skill sets to manage complex patients that may be suffering with chronic pain, mental health comorbidity, and trying to also help them develop the self-efficacy to also address opioid use disorders in patients. I was very fortunate to be able to pilot this curriculum this past academic year. And it was basically through the support of the Arnold P. Gold Foundation. I had resubmitted a proposal for a Picker Gold GME Challenge Grant, and I had formed a team to work on this curricular project that was interprofessionally designed to bring trainees not just within the residency programs, but other trainees that are going to inherit the complexities of dealing with an opioid epidemic as we're facing in the United States. And so in essence, we had about a year ago received the announcement that we had some funding through the Gold Foundation to implement this curriculum that would hopefully help curtail some of the mortality that we're seeing with the opioid crisis. You know, this is a very complex situation from a public health perspective, and what we don't see in most primary care-based residency and training programs is we don't get a lot of behavioral health training. We don't really have the ability to give our future healthcare workforce the competencies to effectively manage patients that have complex chronic pain conditions, and again, those who also may be suffering with opioid addiction. And so in essence, the IPE pilot curriculum served as at least a foundation to provide some of that necessary education in a very much interprofessional setting where we brought trainees not just from residencies but trainees from other health disciplines like the PA and NP programs to learn together on how to develop the teamwork and expertise to hopefully have greater self-efficacy with managing this crisis that we're seeing. And so in essence, we were able to pilot this curriculum last year. We offered 5 distinct IPE sessions over a 6-month time frame. We couldn't do one in February because of scheduling and logistical issues, but we were able to start it in December of 2017 and continued up until May, of which we had a variety of content, what we felt was high impact content that is needed to instill in our trainees to have better capabilities with managing the complexity of these situations. And so we used a pre and post curriculum design, and so we actually assessed baseline, the baseline self-perception that the learners had in terms of where they are with managing chronic pain, where they feel they are with managing mental health conditions. In addition, where they are with their self-perception of how they work in teams and identify themselves as a member of a team. And with the questionnaire that we did at baseline, we then repeated it at the end of the IPE curriculum. So after May, after the last session, we then disseminated the questionnaire again to see if there would be a change in those self-efficacy scores, in those perceptions of working in a team. We don't have the full analysis completed yet, but so far we are seeing the preliminary interim data analysis, some differences in those participants who participated in the curriculum versus the trainees that did not. There seems to be improved self-efficacy for the trainees who actually participated in some of these training sessions that we offered. And these are just the flyers that we had developed, my team and I. So yeah, that's pretty much in a nutshell, what it was. One of the collaborators on this project is an addiction psychiatrist at Johns Hopkins, who I actually connected through the Gold Foundation. Dr. Meg Chisholm has done a lot of research on opioid addiction in pregnancy. And she actually facilitated our March IPE session by addressing the 4 perspectives of psychiatry. And there's a lot of data on using the perspectives in psychiatry to approach substance use disorders, including opioid use disorders. And the focus was on understanding the nature of addiction. We need to be able to do a good social history was one of the take-home points that she addressed, but also the family history. When one starts actually delving into family history, it's from a clinical perspective, we can actually get a lot of information, because if there's a substantial family history of depression, that in itself could be a linkage to why the patient may have been predisposed to developing addiction and everything. And so again, it just comes down to appreciating the unique approaches that we can take as clinicians who are trying to help our patients that are suffering. And some of our patients are just suffering with chronic pain using the opioids, but we need to be able to dissect is it truly chronic pain, or is there something else that's going on that's complicating this, like mental health, comorbidity, or a possible, opioid use disorder that may have complicated the patient's situation. And so I think bringing awareness to our trainees was an important feature of the IPE curriculum. And so, I'm hoping that, for those that participated, that I do believe they took something away. And I think at least, even if we can't expand it in the absence of full funding, although we're doing something at the medical school level, in the next year, but at least I think the trainees that participated are actually have gained some additional skill sets, and I think, if anything, recognition that we need to treat addiction as a chronic disease. So it's very humbling when we see the sequela of opioid addiction, to the point where patients lose their families, they lose their homes, they lose their livelihoods. And there's no clear-cut. There are some prediction, factors that we can see, especially the genetic predisposition. If there's a family history, that can increase the likelihood of that. And so in terms of taking a step back and trying to make it practical, the training that we're offering, I think a lot of it came down to bringing recognition to this public health issue, the substantial public health issue, as a health issue, as a chronic condition. And that there are effective treatment modalities that are available, like through medication-assisted treatment. And I'm not here to misrepresent who I am. I'm a primary care physician. I'm a primary care educator. I don't have full expertise in addiction medicine. I'm not here from that angle of being an addictionologist who has vast experience of managing patients with this. But what I do come in is with this real experience of being on the front lines of care and seeing patients come to their primary care clinic as their first stop, and asking us to help them when we don't even have the existing infrastructure in our communities to effectively do that in a cohesive fashion. And so the lessons that we offered, or these IPE sessions that we offered to the trainees, were a way of bringing awareness to the fact that we should not stigmatize mental illness. And substance use disorders are mental health conditions. Sometimes it's hard to tease out, what you can't always determine what came first. But the fact that a lot of patients who suffer with opioid use disorders do have a complicating factor of a comorbid mental health condition lends to the fact that in order for them to recover, we need to be able to effectively address the mental health aspect, the behavioral health aspect. We need to build the healthcare infrastructure to effectively address that. And that's where I feel some of the communities are not successful at. And I can speak personally to the own community where I practice and I teach. And so the sessions in itself, the curriculum at least provided some awareness to the challenges, and I think one of the most powerful takeaway points that the trainees had talked about when we actually brought a select few in for a focus group discussion was the fact that we brought in a patient who gave a testimonial to how she was dealing with chronic pain and she was judged. The healthcare system, the healthcare clinicians that she would see judged her. She got to the point where she couldn't get the care she needed in our community, and she actually sees a specialist, a pain specialist, 90 miles away because she couldn't get the help that she needed. And this could have been somebody who is, who, although being very highly functional and successful in her career, if she didn't seek the help elsewhere, may have ended up in a very dire situation. And to me, that's very heartbreaking, that we see these patients that have no support. They don't have social support. We see the social determinants of health having a critical impact in their outcomes. And so the curriculum, although not perfect, we were far from being perfect. We didn't have a lot of time to implement this. But what I take away, and what my team and I take away, is that we actually did something to hopefully impact clinical practice change for the future healthcare workforce, again, that's going to inherit this opioid crisis. And so at least bringing that recognition. And one of the final session, by the way, I thought was also very powerful was the one on implicit bias. We had a speaker, one of my collaborators and colleagues, Dr. Javid Sakara, who's from Western University in Ontario, London, Ontario, we had the funding to sponsor him to come to Saginaw to actually facilitate one of the sessions on implicit bias, especially when dealing with patients with chronic pain or even those with opioid use disorders. And we have to get rid of the stigma. There's no way we're going to be able to curtail this and the alarming statistics we're seeing if healthcare clinicians on the front lines don't recognize that there is stigmatization to this and recognize that we all may harbor some implicit bias. And so when patients come in, I mean, the point of the Plane Tree Conference here today is to really build that relationship-centered care, that concept of having that relationship, that patient-clinician relationship for the longitudinal time frame, and to be compassionate and empathic in our delivery of care. And I think that at least we were successful in that regard, giving the trainees that additional knowledge on recognizing chronic pain, recognizing opioid addiction as a chronic disease, as opposed to perceiving it as a moral failing, which is what our previous U.S. Surgeon General had brought to the attention, to the public domain with the Turn the Tide campaign. And so again, we're just revisiting what has already been talked about and trying to disseminate that to those trainees who are more impressionable at their level of training, and trying to get them to open up their eyes. And I think patient testimonials have a strong impact. The appropriate infrastructure is having an actual dynamic healthcare team that can help manage that. And when I talk to the addiction recovery clinics, the opioid treatment centers that we have a few in the community. We don't have a lot, but we do have a few in the community. The resources that they have are not just a clinician and an MA. They have They offer peer support in the clinic. There's social support. They have peer recovery coaches that help that patient. There's a lot of community programs in Michigan that have been launched. Hope Not Handcuffs is a huge one, started by Families Against Narcotics, which is a nonprofit community organization that's been disseminated across Michigan. Decriminalizing patients, the people that are using, is an important aspect of that. And that's not my legal avenue that I want to take, but I think that we need to take a step back and recognize that this is a chronic disease, and we should not judge people for the fact that they are dealing with a chronic disease. I'm not going to pass judgment against the patient with congestive heart failure that may have had uncontrolled hypertension. I am not going to have that same amount of bias, but I recognize that sometimes culturally we label patients that are suffering with addiction, and I think being cognizant of it, recognizing it, that we can, if we can bring attention to our own biases when we go to see that patient, saying, I know that I may not be as fair to this patient and objective, but I need to be cognizant that this is still a human being coming to seek help from me, if that helps at all. Well, I wish I could say that it's adapted elsewhere. I know that there's a lot of academic institutions doing a variety of program implementation, curricular project implementation to address the opioid crisis. And many programs have done kind of, one-day workshops, as a way of addressing the opioid crisis. At this point in time, this is a pilot curriculum that we literally just finished a few months ago, and we're now trying to assimilate the data and to actually package the information, to disseminate it, to to hopefully have it gain traction in some regards. And so I don't know, what the ultimate success of this project will be. There are a lot of shortcomings with really taking a risk and launching right into this with a very short time frame to do it, and recognizing that the curriculum may have been deficient in some regards. But I think in hindsight, the team that I assembled to help me and to help our institution launch this curriculum, we did the best we could, with the time commitment required, with the funding that we fortunately had through the Gold Foundation. And hopefully that impact will continue in some capacity, but I can't predict the future. I don't know, how that would necessarily translate into other healthcare settings. But I'm open to ideas, and I'm open to collaboration, maybe even pondering getting other institutions together to see if we can do something more broad scale. Obviously, funding is a rate limiting factor for a lot of these projects because they do take an immense amount of time, and they're challenging. They're very challenging, from a multitude of perspectives. I'm active on Twitter at Perzhinsky is my handle, JPERZSKY, a shortened name. I'm also on LinkedIn, Juliette Perzhinsky, and definitely, I think connecting through social media, those platforms are most helpful.